Welcome, everyone. It's Mark Taylor here from Led Oncology. I'm very honored here to have Alison here to talk about her outstanding journey. We've known each other, I think, a few years now. I think it's a stunning story to learn from. So, hi, morning or afternoon, Alison.
Good afternoon or good morning, Mark.
Yeah, we just entered the afternoon. So, do you want to give a bit of background to how we met? Just give a kind of preceding story in terms of your diagnosis and then talking about how we met, and then we'll go through the journey to explain the story.
I was diagnosed in July 2020 with high-grade serous ovarian cancer, stage 3C. It was in the height of COVID, so my story, certainly at the start, is certainly not typical. I am very fortunate in that I have a background in medical laboratory sciences, which meant ultimately I was able to self-advocate for myself. So I say very fortunate in that respect. Basically, I had very little warning of my diagnosis. I was doing Pilates one day on my front at home, and I felt that something wasn't right. And when I actually stopped and felt, I could feel quite a hard mass in my abdomen. With the knowledge I had, my mind went immediately to carcinoma, and I contacted my GP and asked for an ultrasound. Fortunately, I had private healthcare, so I was able to get that organised quite quickly. But when I had the ultrasound, I turned around to the radiologist and said, I need to see the screen. I'm pretty convinced I've got carcinoma. So she did actually, probably against all advice, she actually shared the screen with me, and there it was. Despite my suspecting it was going to be carcinoma, it was still an absolutely massive shock. I then set about having to organise my own CT scan and blood tests and find a surgeon, which eventually I managed to do. I'd started with a local surgeon in Cambridge to do the primary debulking surgery, but he couldn't find an anaesthetist. He couldn't give me an update. So I knew time was of the essence. So I then went online, found myself somebody that seemed to be an extremely good surgeon at the Royal Marsden, who was also using plasma jet ablation, and I knew that was going to give me a better chance of disease clearance. So I contacted him. I have to say he was the first human I had actually met on my journey. He was kind, compassionate, understanding, and very matter of fact, and he was the first person I trusted, which I say was very important going into a potentially 7-hour op. He had an anaesthetist on board. She drove 2 hours from Cambridge to the Royal Marsden to do my surgery, and my surgeon and anaesthetist gave up the whole of their Saturday to do my surgery. So I was extremely fortunate. And post-surgery, I was NED on scan, and I believe that was the first good step in my journey, because I was lucky to have achieved complete disease clearance with the right surgeon and using the plasma jet ablation as well. I then went on in January 2021 to have 6 cycles of carboplatin paclitaxel at the Royal Marsden in Chelsea. Again, it was a fairly difficult experience. There was again no real compassion or understanding from any of the staff at the Royal Marsden. It was a very cold environment. I then fortunately found out I could have my last 3 doses of chemo at home, which was a very different experience. And at that point, I got talking to one of the senior nurses that came to visit me at home, and we started to talk about integrative oncology. And that was where my research really started.
That's where everyone's got a turning point, right? And this,
Everybody's got
yes.
exactly right. That's where my interest was sparked. My interest was further sparked by the meeting with my senior oncologist at the Royal Marsden, who was 20 minutes late for my appointment, strode into the room saying, I'm late, I just need you to sign the consent form for your chemo. I said, well, I've got a lot of questions here. She said, no, I don't have time for those. Basically, your cancer is very aggressive. It's going to keep coming back. But don't worry, we'll keep hitting it time and time again with full dose chemo. And by the way, you've only got a 20% chance of being here in 5 years' time. So that for me was a massive incentive. I think for most patients that would have been devastating. for me, I said, right, okay, I absolutely now have to advocate for myself. I'm going to control this journey if I want to be here in 5 years' time. So in a way, what she said to me, in my particular case, I don't think it'd be the same for most patients, that set me off absolutely on my own journey and on the integrative oncology pathway.
Yeah, that switch to realizing that it's on your own half, and quite often that's on the realization that the outcomes are not good, and
Yeah.
that I see is, one of the key decision makers that people need to make and need to go through in order to get good outcomes, right? You could have gone both ways. You could have gone depressed and moped and become the victim, but
Yeah.
control is a key part.
I was lucky because I said earlier, I got the medical background, so I felt fairly confident researching and making my own decisions with the help of, experts along the way. I was then post chemo, I was offered a PARP inhibitor, niraparib, but again, from my own research, I was BRCA1/2 negative, I was HRD negative, and I felt it was very unlikely to work for me. And I didn't want to feel ill for any longer than I had to. And actually, later, the genetic profiling I've had done showed that niraparib would, in fact, have been totally ineffective for me. So I made the right decision there. I then continued with some sort of supplementation and things. I had a very good integrative oncologist that I engaged with, a Belgian doctor who unfortunately is Etienne Calabou, who unfortunately is no longer with us, but he was very knowledgeable. But working remotely, he gave me a supplement protocol to follow and various advice on nutrition and things like that. But then unfortunately in October 22, I had a recurrence. Fortunately, it was encapsulated. I had a 6 centimetre sausage-shaped para-aortic nodal mass. And again, I had fairly extensive surgery at the Royal Marsden to remove that because it was in a very difficult place. So again, it was another 6.5-hour op. But post-operatively, I made the decision that I absolutely did not want to have full dose chemo again. That was the only thing that was offered to me by the Royal Marsden. It seemed to be the only thing on offer in the UK because it was standard of care. So I made the decision to go abroad to a clinic in Istanbul, a reputable clinic that I knew about. And that's, I think, Mark, where we met because you recommended chemotherapy to me. What appealed to me about chemotherapy was that they were offering a number of integrative treatments alongside the chemo. So that would hopefully reduce my side effects and also hopefully make the chemo I was having more effective. So there I had 50% dose of cisplatin and gemcitabine, and that was given along with IVC, hyperbaric oxygen, curcumin, Avastin, a few other things as well. Now, the amazing thing about that was I actually felt incredibly well, despite the fact that I was there. I was having full, 50% dose chemo. I was traveling back and forwards every 2 weeks. My clinic visits were 3 days at a time. First day was chemo with some integrative treatments and then 2 days of continuing integrative treatments. But as I say, throughout it, despite losing my hair, which is, for any woman the alopecia is really awful. I say I felt fit and well, and I really was also continued to be well after I'd finished my chemo as well. So the traveling it was a lot of travel, but it didn't really affect me. I was fit and healthy enough to do it. And that to me, really underlined the difference of having lower dose chemo, but having integrative treatments alongside chemo. It just makes an absolute huge difference to the, well-being of the patient in general.
Yeah, delve into that a little bit, just because the science is not well known amongst the population. Many people are doing off-label drugs, supplements, but to experience one of these metronomic dosed chemo clinics, it only happens in a small number of patients. And I think, the real benefit from most patients is the protection of the immune system, and that's really kind of one of the many benefits from it that unfortunately with a lot of people who've been through high dose chemo, and we see it in the clinics I work with and patient after patient, is quite often there's an incredible long-term damage, and that's it's been studied, and long-term outcomes if you ever switch to immunotherapy cocktail are dampened massively. And I think getting that message out for people, the decision point, and you were really, really lucky in making that decision and firm thing, I didn't want high dose chemo, to allow the rest of your story to really unfold. And going into some of the science there, so I think they get 50% dose every 10 days, right? I think it's roughly what they do, but then they bolster the 50% with vitamin C. I think they use DCA, 2DG, local hypothermia, full body hypothermia.
Yeah.
Yeah, both protects the body and also increases the effectiveness of the chemos.
Yeah. I knew by that stage that if I went for full dose chemo, not only was I likely to develop very quickly chemo resistance, which is very common with ovarian cancer, but I also knew, as Mark, as you just said, that it was really going to limit my treatment options further down the line. And I was very anxious not to destroy my immune system any more than I had to, because, we need our immune systems intact to fight cancer naturally. So it was an absolute consideration and that was really, I say, why I decided that I was not going to go through full dose chemo again and never would.
And then, on a consult, we also talked about testing and other things. So do you want to talk about how you handled the use of your specimen from surgery as well?
Yes, indeed. I asked for an additional paraffin block of my tumor tissue from surgery to be kept, because I knew that I might need that for genetic profiling. And in fact, that was the case, because when I went to, again, under Mark's guidance and help, I decided to go to Medica Mediterranea in Valencia. The prime reason for going there, besides having integrative treatments, was because I had decided that having had the recurrence, I needed to do something else. And I decided to have a personalised neoantigen vaccine. And for that, I needed the paraffin block for the genetic analysis needed to develop the vaccine.
Yeah, and this is a key thing, I'm trying to promote in these types of communications, is the value of that tumor that people have in that can be done with it, both for testing and the creation of vaccines. A lot of people wait right until the end of their journey, when they start looking for alternatives, when it's a bit too late. But, getting it when you're potentially in the position where you've got no evidence of disease and you can deliver the vaccine and then make use of it down the line.
Yeah. I mean, obviously, the benefit of any paraffin block where it can be used is that it'll keep preserved tissue for many, many years.
Yeah, and you managed to persuade the Royal Marsden to do that, which is
I did. Yeah, I had a very good relationship with my surgeon. Was amazing. He was an amazing guy anyway, and I also got to know his PA extremely well, and she was able to organise with histopathology at the Marsden to take an initial additional sample rather, and put it into a paraffin block for me, which she then posted to me. So.
Yeah, that was sent to Next Gen Oncology. I think you became the first of many in the Valencia clinic. The Valencia clinic for me was more, it was me as a cancer researcher, a place where the doctor agreed to kind of do almost everything in the integrative space so that we could learn holistically on a whole combination of things. So I think you were the first person to actually get the neoantigen vaccine.
Yeah, I was. Yes, Martin Luzpatak from Next Gen Oncology actually came over to do my first vaccination himself, and he was training the team on how to administer the vaccine, basically.
Yeah. So. And I was there. I got to experience you holding in the pain from the vaccine.
Yeah, no, the subcutaneous injections were incredibly painful. Yeah. Yes, yeah.
That is a topic that's ongoing.
Yeah.
And then you also got some genetic testing. Now I'm keen now to show everyone what that testing looks like, because I think what people don't realize is what can be done. So what Next Gen Oncology allows is a quite detailed understanding of what's going on within the immune system, and it gives a kind of score for how infiltrated the tumor is with immune cells. And yours was at that stage had a very minor, low to medium infiltration. With ovarian, I think the objective response rate to checkpoints alone is around 10%, but usually quite minor responses. And this largely because of this immune recognition or immune surveillance is not quite there with ovarian. You are not there with a high mutational burden or with microsatellite instability. So the probability of a response to checkpoints alone was not high. And the point of the vaccine really is to increase that immunogenicity. So then you took the vaccine, you started getting some treatments, and we attempted the checkpoints the first time around, I think after a few months of you getting the vaccine, right? And then you had some side effects.
Yeah, unfortunately, after a few months of checkpoints, I think I had CTLA-4, PD-1, might be one other. But basically, I developed microcolitis and I had to continue the CPIs, but I continued then with the vaccine. Do you want to talk about the ELISpot test we did in January, Mark?
Yeah, let's bring that up. I think that's a test that many are not aware exists as well. So this thing, immune surveillance, immune memory. Not many people are aware that that you can actually measure actually how effectiveness something is. So let me just call up this Lee spot so we can see it. This is a response from NextGen, right? It's basically because they do the analysis of your tumor to make the vaccine. They know which neoantigens they've trained your immune system to see. And they do then a similar test with the neoantigens in peptide form with your immune system in a petri dish, and it came up with some degree of immune recognition, right? I think
Yeah.
a number of the mutations were identified and some not, correct?
Yeah.
Yeah. So I think, this topic of immune memory, I think, is the main obstacle for those that believe their tumors are not responsive to immunotherapy working. And I think once this approach that you've gone through, taking a vaccine and testing to see if the vaccine has worked, I think this will start to become common play in this world that we're working in, and it won't be long before we're regularly checking to see is my immune system seeing my cancer in some form.
Mhm. Yeah.
While we're here, I just wanted to also show, on the detailed analysis you did with NextGen on expression profiler, there's also so much information that can come out that people are not aware of. And I just want to use this opportunity to kind of just give an indication of how much information is available, right? So sensitivities to various things based on theoretical analysis, what's going on in the tumor microenvironment, immune suppression aspects. This was also an indication of how many immune cells were in the tumor at the start, and you had a relatively low. This is compared to a median number of T cells prior to vaccination. And I'm not going to go through this report. This is another one showing the immune parameters versus baseline, and again quite low. And then, the amount of testing that goes on, specific oncogenes that are expressed where specific vaccines can be made. You didn't get a survivin vaccine along the way, did you? We didn't.
No, I didn't do that in the end. No.
Do that, yeah. So that's an option for some people. If they've got a specific oncogene raised, there are single vaccine oncogene approaches that can be adopted. Yeah, and it goes on oncolytic virus sensitivity. I'm just going to flick through it, but 130 pages of analysis of things that can be done, and that's really, I think, the pinnacle of oncology did today. But I'll close that for now, and we can get on with the story because there's still a lot to cover. So we've got to the stage where we show that you've now got immune recognition, checkpoints are not working, and you have a recurrence.
Yes, in May 2024, I had a CT scan which unfortunately showed recurrence in an unspecified number of nodes because they were quite widely spread, really all the way from thorax down to the pelvis. So it was, again, a bit of a shock, but I thought, right, I've got to do something different here. I consulted the Royal Marsden again, but they were only willing to offer full dose chemo, which of course I absolutely did not want. So I then decided that I would start to look at the option of immunotherapy, which is absolutely not standard of care in the UK for ovarian. But in the course of my research, I'd learnt about the Israeli company's Cure Response test, which puts live tissue samples, live core tissue biopsy in the laboratory up against various drugs that have been selected. You're allowed to select, I believe, a panel of 8 different drugs or combos of drugs. So I found myself a new oncologist, John Krell at the LOC in London, who was very pioneering, very forward thinking. He was happy to support me in having the Cure Response test, which I did have to fund myself, but he helped me in selecting the 8 drugs, and some of those were chemo drugs, but some of those were also immunotherapy drugs. When I got the test results back, it showed that besides some chemo drugs, that the combination of pembro and lenvatinib should actually work for me, and he agreed to prescribe it. And I was very lucky in that my insurance company also agreed to fund it. But the main reason for that was because of the Cure Response test. And that also meant, as is the case with any oncology treatment in the UK, it has to be signed off by a MDT, multidisciplinary team, and they actually signed it off as well, even though, as I say, it wasn't standard of care. And it was because the Cure Response test, the science had shown that those drugs should hopefully work for me.
Green now, so I'm showing the thing here. So it's the pembro lenvatinib
Yeah.
And I think this is fascinating because I think there's a view that the UK oncology system in mainstream, is not very creative. But I think, this is the first case I've seen of like really high-end thought put into how they're driving treatment. So I think
Mm.
it's a very promising sign of things to come.
Yeah, I was really lucky to have an oncologist that was prepared to do the best for his patient and, go outside the norm, really. So I started the treatment in August. I was only able to have Pembro. That was, last August 24. I was only able to have Pembro because I had to have 2 dental extractions, and then lenvatinib is quite risky with bone. You can develop osteonecrosis of the jaw if you have lenvatinib with a major dental extraction. So I had to have 2 successively, so that I wasn't able to start the lenvatinib. I was on Pembro alone, and I had a clear scan this January and another clear scan 3 months later, and that response has been on Pembro alone.
And a complete response, right? Tumor
A
markers
complete
normalized.
response.
Yeah, normalized.
Absolutely, yeah. I mean, I never had significantly raised tumor markers anyway. My CA-125 was 255 on my original diagnosis, but it's never really been raised above 17 since then, actually. So CA-125 has never really been indicative for me other than the initial diagnosis.
Yeah, and I had a look online for the probability of a complete response, and I think there's one case seen in all the studies. I didn't look into it, but it was possible that it was in a high mutational burden situation. So
Yeah.
it's incredibly rare, but the steps you went through were logical, and particularly the combination of the vaccine, giving the immune surveillance, giving the immune memory, so the immune system can see it, and then the checkpoint following up.
Yeah, of course, what I'd also done in July prior to starting my immunotherapy, I went to Miami. Again, Mark, the contact that you knew. I went to Miami for PEF, pulsed electrical field ablation with bleomycin, because I knew again that would perhaps help as a primer for my immunotherapy as well. Because my lymph nodes were so widely dispersed, my metastatic lymph nodes, Dr. Curtis Anderson was only able to ablate around 30% of the affected nodes. But, the benefit of the treatment was, again, that it was hopefully going to, prime and wake up my immune system, prepare me in the best possible way for a response to immunotherapy.
Yeah, another very interesting combination, all synergizing with getting the immune system to see the cancer. And then I think what's also really fascinating is your integration of integrative oncology, the softer side. Can you talk about I think the story about you getting over the side effects from checkpoint inhibitors is a fascinating one.
Mm-hmm.
Do you want to talk about how you used your Nina to help you through that?
Yeah, sure. So another reason that I had selected John Krell as my oncologist is because I knew he was one of the few oncologists in the UK who believes passionately in integrative oncology and the power of integrative oncology, and that key relationship of a conventional oncologist working alongside an integrative oncologist. So I knew he was working with Dr. Nina Fuller-Shavel, who is an excellent integrative oncologist. She has a clinic near Reading. But she has so many patients that really one of the main ways to get on her books, as it were, is through referral. So John Krell referred me to her. She knew my history of autoimmune thyroid, which is really obviously presents some major challenges with immunotherapy. As we talked about earlier, I'd had to come off CPIs when I was in Valencia because of the microcolitis that I developed. Dr. Nina is very much into the importance of having a good gut microbiome to support patients, particularly with immunotherapy, and to very closely monitor whatever needs to be monitored. And in my case, that is my thyroid profile. Basically, every time I go for my Pembro treatment, then I'm having a full blood profile done beforehand, including thyroid function tests, detailed thyroid function tests. Those results then go to Dr. Nina. She looks at those, and we are making micro adjustments to my thyroxine levels. I am on both levothyroxine and I am also on liothyronine T3. So again, it's quite a complex picture, but we are literally micro adjusting the doses every 3 weeks to support my thyroid as well as possible, which is being impacted by the immunotherapy. But we're also doing regular microbiome testing, again, so that we can, and adjusting that with probiotics, etc., to make sure my microbiome is as stable as possible, which obviously improves my tolerance of the immunotherapy. So although I've had a few little ups and downs with some SIBO and some very minor colitis, we've been able to manage those symptoms very, very adequately with pre and probiotics. But also Dr. Nina has got a qualification in TCM, traditional Chinese medicine. She's a qualified herbalist. So again, she uses herbs quite extensively as well to treat patients, to again manage any side effects from their treatment. She's also a qualified acupuncturist as well and nutritionist. So she has many strings to her bow. So in doing that, we've been able to really avoid to date me having to take any steroids, antibiotics, etc., to manage my symptoms, which again is really important because her focus is on trying to modulate everything so that the use of traditional drugs is minimized, and therefore the disruptions to the microbiome, etc., is minimized, because that's obviously key to my response to the immunotherapy.
Yeah, this is, it's fascinating to me because so many intelligent pieces of advice along the way that you received. For most patients, they go on checkpoints, they have side effects, they're straight on steroids, and it's kind of game over for that
Yeah.
front. Having
Totally.
doctors now that are aware of that, there are very few that can help you navigate that journey. When you've already got an autoimmune disease, it's almost crazy to see that doctors are actually capable enough of helping someone with an autoimmune disease through it, because even those
Yeah.
without autoimmune disease quite often have side effects.
Yeah, definitely.
And the other thing I wanted to talk about is more on the mind body. It's something that I talk about in my group and
Yeah.
my book. And can you talk about what you did in that space as well?
When I started looking at the whole integrative oncology side of things, and also conversations I had with you, Mark, I kind of realized that this trying to change life and be in the parasympathetic state as much as possible is absolutely key. When I look back over my life, I can see the stress that led to my development of a cancer in the first place. I can see it extremely clearly. I can see a whole series of events. When I developed autoimmune thyroid some 30 years ago, that should have been a wake-up call, but nobody knew anything about it. I certainly didn't know about it. You get treated with thyroxine, that's it. That's a wake-up call. We now know that things are starting to go awry. I sort of realised that it was very, very important to change my lifestyle and learn to relax and get into that parasympathetic state as much as possible, be that through meditation, but also I became aware that, there was a lot of probably hidden stress, past traumatic stress events that were probably sitting there in my subconscious. The more I read, the more I felt that was the case. So I decided to go on a psilocybin MDMA retreat. And what came out of that was fascinating for me and life-changing. The things that I felt in life were the key stress events for me, things sitting, in my subconscious. It turned out it was something completely different that was the main stressor for me. I had a very painful divorce 20 years previously, and I was still carrying the guilt from that. This all came out in my first psilocybin session, where I cried continuously for 5 hours. I'm not good at crying, but the release was absolutely massive. And actually, it was the first time I had allowed myself to grieve for myself and my illness, and actually feel any sort of sympathy for myself, really. And that again was very important. It was done under the whole retreat was under with a very good psychiatrist that Mark knows, again near Alicante. We had a day's gap. I then did the MDMA, and that for me was an amazing experience. I felt huge gratitude for everything in my life and the point I was at. And I was also able to say goodbye to the things in my life that I needed to say goodbye to, the things that had been sitting there and bothering me in my deep subconscious for goodness knows how long. But such a life-changing experience, I've decided that this summer I'm going to do another psilocybin retreat along with San Pedro, because I'm sure there's more things I need to release. But I know that, I say, being in as de-stressed a state as possible is so important for healing from cancer. And I believe that every cancer patient should be looking at the sort of the the mind side and the stress release side as well.
Yeah, from my experience, on myself and from following others, and having been through conventional medical treatments for psychological distress, it's interesting how few people understand the concept of trauma trapped within the system, and emotions trapped within the system.
Yeah.
Like that's what Chinese medicine said thousands of years ago.
Yeah.
If I see this time and time again with myself, with others, is that they do the psilocybin therapy, and then a memory comes up, and then the emotions start clearing, and then they're in a different emotional state afterwards. And it's kind of surprising that something as a mode of clearing and a bad emotional state is so simple. It's just accessing it, the emotion, and releasing it. And I think in a lot of patients totally misunderstand what drugs like psilocybin do. A lot of people that choose not to do it fear losing control, fear, I like having control, but actually what they don't realize is they don't have control because they're carrying all this trapped emotion, and
Right.
they're a victim of all the emotions they're carrying.
Yeah, absolutely.
The persona becomes the emotions they're carrying. They think, I am an angry person, I'm an anxious person, I'm a sad person. But really, it's all these things that can be removed.
Yeah, totally.
Key to get out there, because few are brave enough to do it. And and I see you now as a different person. You were a different energy when I first met you on the
Yeah.
call.
Yeah. No, it's been an amazing journey, and that's been a huge part of it too. And I think every cancer patient should do psilocybin. Totally.
Yeah, and I was at the IPM conference last Thursday and Friday, and one of Britain's top psychiatrists is now heavily involved in this space and trying to push it through Parliament. So hopefully we'll get some shifts in the next year or two.
Yeah, hope so. Yeah.
What an amazing journey. There's so many layers to it. The choosing not to do high dose chemo, the finding a metronomic chemo that will look after your immune system while it puts you through treatment, the getting the testing done early, the getting the vaccine made, the getting the testing done by Royal Marsden to open up the doors to immunotherapy, to an integrative doctor that can handle autoimmune diseases, the mind body. It's literally a perfect journey. And there's very, very few patients I see that have a very difficult situation and get to the state you're in. So well done. And it's a great story for others to learn from.
Okay, thank you very much. Yeah, there's an element of luck in there, and thank you for your help on the journey too. You're amazing. Thank you.
Thank you very much. Chat soon.
Yes, indeed. Thank you. Bye.
Bye.